Hello and welcome. Today our group will be presenting to you a module on a type of stroke known as Wallenberg syndrome. Now, let us get started. Wallenberg syndrome, also known as lateral medullary syndrome, is a range of symptoms caused by the result of ischemia to the lateral part of the medulla oblongata. The most commonly involved arteries are the posterior inferior cerebellar artery and the vertebral artery. It is these two vessels that are the main sources of blood supply for the lateral medulla. Of the 20% of posterior circulation strokes, Wallenberg syndrome is considered to be the most prevalent among them. Since lateral medullary syndrome has varied neurological manifestations, it is often missed by those outside the field of neurology. Thus, it is important for us to be able to recognize these presentations as healthcare professionals. The etiology of lateral medullary syndrome includes atherosclerotic disease, which can develop into a wide variety of complications such as thromboembolism, the dissection of vertebral arteries, cardiogenic embolism, small vessel diseases, moyamoya disease, and vertebral basilar dolichoectasia, along with a few other less common causes of ischemia. When thinking on the etiology of lateral medullary syndrome, the risk factors for it are in line with those of atherosclerotic diseases. As such, these factors mainly include hypertension, being the most common of all, followed by smoking and diabetes mellitus. So, what is the pathology of Wallenberg syndrome, and how does it cause the clinical presentations? Ischemia to the dorsal lateral medulla, which is highlighted in red, results in the dysfunction of all structures in that area. The hypoglossal nucleus, tractus solitarius, nucleus ambiguus, and the reticular formation are all involved in the swallowing center. Their damage leads to ipsilateral laryngeal, pharyngeal, and palatal hemiparesis, resulting in the presentation of dysphagia, hoarseness, and the absence of a gag reflex. The solitary nucleus also contains the dorsal respiratory center that is responsible for maintaining the rate of respiration. Its damage can lead to hiccups or even respiratory failure. The vestibular nuclei and/or the vestibular cerebellar tract, through the damage of the inferior cerebellar peduncle, explains the symptoms of vestibular dysfunction. These symptoms include nausea and vomiting, vertigo, nystagmus, diplopia, and severe gait ataxia. The lateral spinal thalamic tract here has already decussated, and its damage will result in the loss of collateral pain and temperature sensation of the trunk and limbs. As for the face, the impaired subnucleus caudalis of the trigeminal nerve would result in the ipsilateral loss of pain and temperature on the face, as the nucleus has yet to decussate. The descending sympathetic pathway and vagus nerve's dorsal nucleus involvement would result in ipsilateral Horner syndrome and deranged autonomic cardiovascular regulation. From the presentation of Wallenberg syndrome, we need to differentiate it from other diseases such as other causes of vertigo, especially peripheral vertigo such as acute labyrinthitis. It is something we can consider in patients who may be younger and without many vascular risk factors. The nystagmus in patients with acute labyrinthitis is peripheral and unidirectional or rotary. There may be associated tinnitus as well without any other brainstem signs. The head thrust test will be positive, which, if present, is the most helpful in differentiating a central cause, such as Wallenberg syndrome, from a peripheral cause. In the case of hemorrhagic strokes, they are usually much less common, and headaches are more prominent. To differentiate it from acute demyelination in multiple sclerosis, the patients are generally much younger and are more likely to be female with a known history of demyelinating disease. And finally, in an acute relapse of neuromyelitis optica, the area of involvement is the postrema. Patients are commonly female young adults and have signs that may suggest more than one central nervous system lesion. The diagnosis of Wallenberg syndrome is usually made from a clinical exam and the history of presentation. The initial assessment of full patient history is important while different tests are being done depending on the time after the stroke. Physical examination such as head impulse, nystagmus, and skew test can suggest possible stroke, warranting to further evaluation for imaging tests. CT scans are used to differentiate ischemic from hemorrhagic stroke. Large ischemic strokes are more evident on a CT around 24 to 48 hours post-stroke. MRIs are more sensitive for small infarcts in all areas of the brain, including the cortex and the brainstem. Diffusion-weighted MRI is by far the best at confirming an infarct in the inferior cerebellar area or lateral medulla, and this can be done within minutes after the onset of symptoms. MRAs are also very helpful in identifying the site of vascular occlusion and help to rule out any uncommon causes, such as vertebral artery dissection. The management of Wallenberg syndrome includes resuscitation and intensive care unit monitoring. Respiratory failure should remain in mind, and patients need to be followed up in the intensive care unit. Patients should be clinically monitored for signs of increased intracranial pressure. These include disorientation, lethargy, headache, and vomiting. It is also important to watch for bradycardia, hypertension, and other irregular respiratory patterns. Management includes head elevation to 30 degrees to prevent aspiration pneumonia, blood pressure management to maintain cerebral perfusion, hyperventilation, osmotherapy, and sedation. Doctors should consider reperfusion or thrombolytic therapy. Intravenous thrombolysis using IV recombinant tissue plasminogen activator and endovascular thrombectomy may be an option. At the same time, there should be monitoring in case of a secondary stroke. By taking cautionary measures, it can be prevented with antiplatelets, antihypertensives, and statins. It's important to treat the cause as soon as possible and remove what vascular risk factors we can. A medullary infarction can cause autonomic abnormalities, leading to acute heart failure, and as such, a pacemaker may be required. Keratitis and lateral medullary syndrome can also occur. These patients need multidisciplinary management, artificial tears, night creams, autologous serum, and rarely surgical procedures. Physiotherapy is an essential cornerstone in the management of lateral medullary syndrome. Inpatient rehabilitation is also necessary, and there should be regular follow-up for speech and motor evaluation, as speech and occupational therapy are crucial for daily living activities. Lateral medullary syndrome patients require physical and occupational therapy until they gradually develop their own physical strength. Patients should be made aware and educated on secondary stroke prevention strategies. Low molecular weight heparin prophylaxis of deep vein thrombosis should also be prescribed. Those with dysphagia should go through dysphagia rehabilitation, and patients who are not able to swallow may need to see a dietitian. Some patients may also require a temporary feeding tube. Some patients will need to undergo active exercises to help strengthen their swallowing musculature. Lateral medullary syndrome management requires an interprofessional therapeutic approach. Healthcare professionals should focus on stroke prevention. These include proper control of risk factors such as smoking and hypertension. Additionally, blood pressure-lowering medication, antithrombotic therapy, and statins are required. Long-term follow-up is necessary by a neurology nurse to ensure that the patient is recovering. Social workers should be consulted to ensure that the patient's home environment is safe and that there are support services available to them. Some patients may have had a severe stroke, and the end-of-life committee should speak to the caregiver about future decisions regarding care. Patients should then be followed up by the interprofessional team after hospital discharge until they improve in functionality. And with that, this is the end of our module. Thank you for listening to our presentation, and I hope you found our video informative.